Okay, you're able to see that. Good. So congestive heart failure is the leading cause of hospitalization here in the United States and North America, and increasingly around the world, more so than respiratory illnesses and even acute MI, which has actually decreased in recent years. One of the reasons that we're seeing an increase in congestive heart failure is that survival from coronary artery disease from acute myocardial infarction is improving. So as a result, more patients are living longer and healthier, but they're also living with the complications of coronary artery disease, including congestive heart failure. What are some of the other reasons that we're seeing an increase in the incidence in congestive heart failure? If you look at the HIV epidemic, historically, when it first started almost 40 years ago, most patients succumb to the infection itself, usually from an opportunistic infection. As the treatments have gotten better for HIV over the years with better antiviral therapy and chronic disease management, opportunistic infections are much less common, but patients are dying more from diseases of old age, such as cardiovascular disease and cancer. And we are seeing higher incidences of coronary artery disease and also congestive heart failure in people living with HIV. We're also seeing improvements in survival of cancer patients. Over the last 30 years, there's been a substantial reduction in the mortality from cancer. But as a result, patients are developing late complications of cancer treatments, including cardiomyopathy and coronary artery disease. And coronary artery disease by itself is actually the most common cause of congestive heart failure in developed nations, and increasingly in developing and lower income nations. You can see that after an incident myocardial infarction or heart attack, the risk of heart failure increases proportionately, and more so with the severity of coronary artery disease. And also, we're seeing a greater incidence in women. Women do tend to have longer lifespans than men. So as women are growing older, more of them are developing congestive heart failure. That's also compounded by the obesity epidemic, which we're seeing a lot, not only here in the United States and North America, but also increasingly in developing worlds as more and more countries are adopting the so-called Western diet and the Western lifestyle. And also diabetes, as we've gotten better at treating diabetes because of better emphasis on glycemic control and better treatment of the microvascular complications such as nephropathy. As patients live older with diabetes, more of them are developing congestive heart failure. And also hypertension. Hypertension is also the second leading cause of congestive heart failure, and that you can see that the higher the blood pressure is at baseline, the higher the incident risk of congestive heart failure over time. If you look at all three of these curves, both for men, women, and the total, if you look at the very bottom line, the blue line here, even with well-controlled hypertension, there's still an increase in congestive heart failure over time. So that's what causes it. So I want to talk now about the physiology of congestive heart failure. Congestive heart failure is a problem with both forward function, but also backward function. Forward heart failure is a result of inadequate perfusion into the arterial system, leading to poor tissue perfusion, which in turn leads to activation of the renin-angiotensin-aldosterone system, which leads to excessive sodium reabsorption. It's also a problem of backward function. This results from failure of one or both of the ventricles, the right or the left ventricle, to fill normally and to eject its contents, causing increased congestion in the atria and the venous system. What are some of the common symptoms of congestive heart failure? Shortness of breath or dyspnea is probably the most common one, both at rest and with activities. Signs of volume overload, including peripheral edema, are a very common symptom. Symptoms of reduced forward flow can cause fatigue or decrease exercise tolerance, lack of energy. In the more advanced stages, patients report orthopnea. They report difficulty laying flat, and they wake up at night feeling short of breath because of congestion. Other signs of volume overload include an increased abdominal girth, which can cause to swelling of the belly, and also early satiety. Cough, typically with the pink frothy sputum, is pretty typical for pulmonary edema. Polyuria is a result of activation of the renin-angiotensin-aldosterone system, and in the very advanced stages, decreased cerebral perfusion, which can lead to confusion or memory loss, can present. What are some of the physical signs of a reduced cardiac output? Well, it depends on the system you're looking at. As we talked about in the previous slide, if you look at the central nervous system, signs of cerebral hyperperfusion can include restlessness and having confusion, being agitated. Respiratory manifestations include tachypnea, increased ventilation. In the very advanced stages, patients can develop acidosis, lactic acidosis, because of decreased tissue perfusion. If patients have significant right heart failure symptoms, that can present with gut edema, with bowel edema, which can cause decreased motility and also early satiety. In states of a reduced cardiac output, you can see oliguria as well as inuria in stages. Other signs leading to shock include a deep capillary refill and cool and mottled extremities. And then finally, some of the physiologic signs that we see are tachycardia and also reduced peripheral pulses. Typically, in the cardiac exam is where we'd like to focus for the diagnosis of congestive heart failure. Typically, the point of maximum impulse of PMI is usually in the fourth or fifth intercostal space in the left midclavicular line. However, as the heart dilates, as someone develops a cardiomyopathy, it gets displaced both inferiorly and also laterally. So that can be a sign consistent with congestive heart failure. Sometimes you could feel a hyperdynamic precordium due to increased cardiac output or the presence of left ventricular hypertrophy. The chest radiograph also plays a role in diagnosis. These are some of the classic findings that we see with congestive heart failure. You see increased lung markings and the so-called curly B lines, which are those horizontal markings off to the left there. Another sign that's very specific for congestive heart failure is an increase in the cardiothoracic ratio. On a standard PA film, on a posterior anterior film, if the cardiac silhouette is more than 1/2 the thoracic diameter, that has a high specificity for cardiomegaly and possibly cardiomyopathy. When you have somebody, excuse me, when you have somebody with excuse me, with new onset congestive heart failure, these are some of the standard laboratory tests that you want to include. Renal function, liver function are important. Complete blood count to screen for anemia, both as a contributing comorbidity for congestive heart failure, and there are some diseases with anemia that can cause congestive heart failure. Checking a BNP level, a B type or aminoterminal pro-brain natriuretic peptide is important both for diagnosis and also for following patients, and it also has prognostic importance as well. Excuse me. Always important to screen for TSH, screen for hyperthyroidism, which can cause about 1% of tachycardia-mediated cardiomyopathies. Other tests to look for would include an HIV test, especially in younger patients with risk factors, given the association between HIV and also cardiomyopathy. I didn't include it on this slide, but screening for hepatitis C is also reasonable too. Hepatitis C has been linked with dilated cardiomyopathy. Some of the less common causes would be to check a ferritin level in iron studies. If you're looking for hemochromatosis or an infiltrative process, checking for Lyme serologies. Lyme disease can present with carditis, which can present initially with heart block, but that can also cause cardiomyopathy as well. And if you suspect acute coronary syndrome, somebody's presenting with chest pain, or if they have EKG change that's suggestive of ischemia, reasonable to check cardiac enzymes on them as well. In our hospital, typically if somebody comes in with new onset heart failure, we generally will check serum troponins to rule out acute coronary syndrome. And then other tests to look for atherosclerosis include an A1C and also a lipid panel. These are the standard ICD diagnoses that we use for congestive heart failure. ICD-10 is used worldwide, and certainly in the United States and in most countries that have government involvement with healthcare. Very important to code your diagnosis accurately, both in the office setting and also in the hospital setting. These are some of the common diagnostic codes that we use to classify congestive heart failure, whether it's systolic versus diastolic. Systolic heart failure is generally congestive heart failure with a reduced ejection fraction, and as most people will say anything less than 40 to 50% is considered reduced or systolic heart failure. Anything over 40, 45, or 50% is considered diastolic heart failure, or heart failure with a preserved ejection fraction. As we will see momentarily, congestive heart failure is really a spectrum. Historically, we always used to classify it very distinctly as being systolic versus diastolic, but as we're seeing more and more with some of the newer studies, the therapies that work for systolic heart failure also work reasonably well for diastolic heart failure and vice versa. So it's really become kind of a spectrum along a range of ejection fractions. It's important because the prognosis for both systolic and diastolic heart failure is similar. This is the paper from the New England Journal of Medicine from about 15 years ago. And depending on how you define, preserved versus reduced ejection fraction, you can see that over time, survival is generally guarded in both groups, both systolic and diastolic heart failure. It's not entirely understood why that is. So one of the theories is that systolic heart failure, even though it tends to be more severe, historically there have been better therapies for it, and they've been implemented much more aggressively. Whereas diastolic heart failure, even though it didn't have as poor of a prognosis, diastolic heart failure tends to occur more commonly in older patients with other comorbidities. And we did not have as well-defined therapies for diastolic heart failure when this paper was published. So, but regardless, the diagnosis of congestive heart failure, regardless of the ejection fraction, is a very serious condition with a very guarded prognosis. It's also important to stratify patients based on their functional class. NYHA stands for the New York Heart Association, and it's a simple grading scale based on the patient's functional status and when they develop symptoms. Somebody who's NYHA class 1 is either asymptomatic or symptomatic only with moderate or heavy activities, whereas somebody who's NYHA class 4 tends to be symptomatic at rest or with minimal activities. And this also correlates very strongly with overall prognosis. The better controlled the symptoms are, the better the patient does. I also want to talk about diastolic function. Diastolic function is what occurs during diastole. We look at the left ventricular filling through the mitral valve, and also having more severe forms of diastolic function also affects prognosis. If you look at the very bottom curve here, the bottom horizontal line here, patients with congestive heart failure who have normal diastolic function tend to do fairly well, whereas patients who have increasing degrees of diastolic function tend to have a poor prognosis, both for heart failure admissions and also for mortality. The right heart catheterization, or a Swan-Ganz catheter, is one of the standard ways that we evaluate the nuance of congestive heart failure. This is on the top left here. This is a model of a Swan-Ganz catheter. The tip is here, and then the blue port is for the central venous pressure or the right atrium. The yellow port is for the distal tip, which is in the pulmonary artery. The white portion here, this is an infusion line, and then a balloon goes onto the end of the catheter here. When it's advanced either through the jugular vein, as shown in this diagram here, or from the femoral approach, which is shown on the right here, it goes into the distal pulmonary artery. When you inflate the balloon, that occludes the arteriolar flow, and then you can measure the pulmonary capillary wedge. And this is part of the standard diagnosis for congestive heart failure. It can also be used to monitor response to therapy, and it's also important for prognosis as well, especially if patients need to be evaluated for advanced therapies, such as a left ventricular assist device or for heart transplantation. And this is what the waveforms look like. When you first advance the catheter into the right atrium, this is your standard central venous pressure tracing, and you can see nice A and V waves here as is delineated there. You then advance to the right ventricle, and it looks just like a left ventricular pressure tracing, only it's smaller. Then you advance into the pulmonary artery, which looks like the standard arterial waveform. And then finally, when you put the balloon up into the distal capillary, you get pulmonary capillary wedge pressure, which looks very similar to the central venous pressure. These are all pretty normal pressures here. Normal CVP should be less than 10. Normal wedge pressure should be less than 15 to 20. And this can be very valuable in also in diagnosing congestive heart failure and also assessing response to therapy. It's also important to evaluate these patients for coronary artery disease or for ischemic heart disease. As I stated earlier in the beginning of the talk, coronary artery disease remains the leading cause of congestive heart failure in developed nations, and there's a couple of different ways we can evaluate for it. In general, the gold standard for nuance of congestive heart failure is to do a diagnostic coronary angiogram, and these are representative angiograms of a normal patient. If you look at the left side here, this is the catheter here. This is the left main coronary artery. This is the left anterior descending artery. This is the first diagonal branch. This is the left circumflex artery over here. On the right side, this is an angiogram of the right coronary artery. Again, here's a catheter tip there. This is the right coronary artery going around. This is the posterior descending artery and the posterior lateral branch. This is a normal coronary angiogram here. And so for a patient like this, you would say that their congestive heart failure is due to a non-ischemic cardiomyopathy or not due to coronary artery disease. There are some exciting developments in use of the non-invasive evaluation of ischemic heart disease. In the top left here, this is a coronary CT angiogram, and there are studies showing that in dilated cardiomyopathies, this is a reasonably accurate modality to assess patients who either may be reluctant to undergo an invasive angiogram or may not be a good candidate for an angiogram based on vascular access issues, for instance. In the middle here is a cardiovascular magnetic resonance imaging scan. This is a coronal section here, and this is the aortic root. This is the left main artery here. This is the left anterior descending, this is the left anterior descending artery here, and this is the left circumflex artery here wrapping around that posterolateral wall. And this over here is the right coronary artery here, and this looks fairly normal. Cardiac MRI can be useful in young patients, especially in children and adolescents, whom you may not want to do an invasive angiogram. And if you're looking primarily for a coronary anomaly, MRI can be a very valuable modality. On the lower right here, this is a PET scan, a positron emission scan using PET isotopes like rubidium to look for blood supply. The nice thing about the PET scan as well as cardiac MRI is that in addition to looking for ischemia, you can also assess for myocardial viability. I'm not going to talk about viability in this lecture, but there is some ongoing research looking at the use of viability to determine which patients will respond best to revascularization. I want to spend the remainder of the talk talking about pharmacotherapy. As I stated earlier, congestive heart failure is a serious condition. It historically had a very high mortality, but there have been great advances made in pharmacotherapy over the last 30 to 35 years, which has substantially improved the symptoms of congestive heart failure, reduced the hospital rate, and also improved survival. This is a slide from what's called the VHEFT trial, VHEFT trial. This was published in the late 1980s. This was the first trial that showed that vasodilator therapy with combination hydralazine and isosodium nitrate, shown in the dots, in the circular dots here, compared to placebo and prazosin. Prazosin is an alpha blocker. This is one of the first trials to show that vasodilator therapy for congestive heart failure substantially reduced mortality over the study period. This next slide is from the VHEF2 study. This trial compared hydralazine isosorbide dinitrate to enalapril, which is one of the earliest ACE inhibitors. And this was the first trial to show that while vasodilator therapy is beneficial, doing so with an ACE inhibitor confers a mortality benefit compared to hydralazine isosorbide dinitrate. I want to talk about the AHEFT study. This is kind of going out of sync. This is a trial that was done almost 20 years ago now. It was published in 2004. And they took patients who were self-described African Americans, and the patients got either a placebo or they got a fixed dose of hydralazine isosorbide dinitrate. The patients were started on hydralazine 37.5 milligrams and isosorbide dinitrate 20 milligrams 3 times daily, and they were increased to a target dose of 75 milligrams TID of hydralazine and 40 milligrams TID of isosorbide dinitrate. This study showed that there was a substantial reduction, almost a 50% reduction, both in heart failure hospitalization and also mortality in patients who received hydralazine isosorbide dinitrate. And this trial kind of illustrated some of the potential genetic and ethnic differences in congestive heart failure between African Americans and people who were not African American. There was some exciting discussions about different isoforms of nitric oxide synthase and so forth. But this is a more contemporary trial, kind of re-examining the role of hydralazine isosorbide dinitrate in systolic heart failure. All of these patients had an ejection fraction less than 40%. Again, just another slide on the AHEFT trial. It showed that there was a reduction not only in mortality, but also in hospitalizations and in quality of life. This therapy tends to be a little bit overlooked, in part because even though hydralazine isosorbide dinitrate are available generically in the United States and in developed nations, it is marketed as a drug called Bidil, B-I-D-I-L, which is a combination pill which contains both hydralazine and isosorbide dinitrate. Some of the insurance companies don't approve the brand name medicine, so you have to prescribe the generic components, and it can be very challenging for patients to take 3 tablets of hydralazine and isosorbide dinitrate 3 times a day, so that can be challenging. However, I do have several patients who were on it who were doing very well on the combination therapy. Digoxin is an old medicine. As you know, it came from the foxglove plant over 2 centuries ago. This is a slide from the DIG trial, the DIG trial, which is a trial from about 15 years ago that showed that compared to placebo, digoxin did not have any effect on mortality, but it did reduce hospitalizations. So in patients who have advanced heart failure who are still symptomatic, digoxin is still a reasonable go-to therapy. I want to spend a couple of slides talking about beta blockers, which is really a game changer for congestive heart failure. Up until about 25 years ago, beta blockers were felt to be contraindicated in systolic heart failure. Beta blockers are a negative inotrope, and there was a concern that if you gave them to patients with an EF less than 35%, it would increase mortality. It was very common, for instance, when patients who had an acute MI, even though beta blockers in the early 1980s were found to reduce mortality in survivors of heart attacks. If you had an ejection fraction less than 35%, a beta blocker was contraindicated. It couldn't be given. But there were some preliminary studies that suggested benefit of beta blockers in patients with heart failure. This is from the Copernicus study. This was published back in 1996. Milton Packer was the principal investigator. And this is a trial looking at carvedilol. And as you can see, there's a substantial reduction in mortality beginning as early as 4 to 6 weeks from randomization. And it was pretty substantial. The thought process is that sudden cardiac death is one of the leading causes of death in people with systolic heart failure, and beta blockers do have antiarrhythmic properties, and this is one of the main reasons that they reduce mortality in patients with systolic heart failure. Carvedilol may also have some benefits in diastolic heart failure as well. While none of the beta blockers have been shown to be definitively beneficial in patients with diastolic heart failure, it is very common for us to give this therapy to patients with diastolic heart failure. And this is one paper looking at the benefits of carvedilol on diastolic function in patients with diastolic heart failure, so-called preserved heart failure. And a second major trial that was conducted a couple of years later was called the MERIT-HF study. This looked at metoprolol XL, which is an extended release version of metoprolol. And this trial also showed a substantial reduction in mortality as early as 3 months following randomization. Sorry, it's my 6-year-old at the door there. So this trial showed a substantial reduction in mortality. A third beta blocker that we don't use a whole lot is called bisoprolol. This was studied in the CB's study, and this also showed a reduction in mortality. We tend to use a lot of carvedilol and metoprolol XL. However, bisoprolol works well in patients who have hypotension, who can't tolerate stronger beta blockers or other heart failure medications. I do have a few people who are on bisoprolol, but they tend to do pretty well on it. Not all beta blockers are the same. So there was a fourth trial called the BEST trial, which looked at the beta blocker bucindolol, which found no benefit in systolic heart failure. There's another trial called the COMET trial, which compared metoprolol tartrate to carvedilol, and it found no benefit of metoprolol tartrate. While atenolol and labetalol have other indications, they are not proven to work in congestive heart failure. In metoprolol tartrate, there was a study in people with dilated cardiomyopathy. While it found no adverse effects, it did not find any benefit either. So generally, the 3 beta blockers that we use in congestive heart failure are carvedilol, metoprolol XL, and bisoprolol. This is another study looking at the enalapril, which this is from the consensus study, looking at systolic heart failure. Again, ACE inhibitors are really kind of the mainstay of therapy, ACE inhibitors and ARBs. There was a study called the ELITE-2 study. This was done in the mid-1990s, which compared captopril, which is the old ACE inhibitor, to losartan, which is an angiotensin receptor blocker. And this trial found that the angiotensin receptor blockers work equally as well as ACE inhibitors. We used to go back and forth on this. Historically, we've always recommended ACE inhibitors as first-line therapy, given the longer track record with ACE inhibitors. However, ACE inhibitors may cause more angioedema and other side effects, such as hyperkalemia, compared to angiotensin receptor blockers. In addition, if you look at the in congestive heart failure, the relative risk reduction with ARBs may be more so than that of ACE inhibitors. So we've kind of re-examined it. Maybe ARBs might be the preferred drug. It's still an area of debate, but they're considered to be equally good for patients. This is from the ValHeft study. This is looking at Valastartan, which is another type of angiotensin receptor blocker. Again, compared to placebo, this drug did have about a 13% risk reduction in the endpoint for congestive heart failure. I want to talk about the CHARM trial. The CHARM trial was actually a series of 3 trials using candesartan, which is another angiotensin receptor blocker. I actually wrote a review article about these trials about 15 years ago. And there were 3 arms of the trial. There was what was called the CHARM alternative, the CHARM added trial, and then the CHARM preserved. If you look at the top slide, the CHARM alternative was using candesartan as an alternative in patients who could not tolerate an ACE inhibitor. And you can see that compared to placebo, candesartan was beneficial. It did reduce the endpoint substantially, basically establishing candesartan along with the other ARBs as an acceptable treatment for congestive heart failure. The CHARM added trial, which is in the lower right there, was an interesting trial. What they did is that they added candesartan to people who were already on an ACE inhibitor. The ValHeft study found no benefit. The ValHeft trial showed that when you add Valastartan to an ACE inhibitor, antispironolactone, they actually found an increase in mortality. The concern was that there might have been hypotension, there might have been hyperkalemia when you combine all 3 of them. So following the ValHeft study, it was generally recommended against to combine an ARB with an ACE inhibitor or all 3 therapies. The CHARM added trial showed that candesartan could be added safely to an ACE inhibitor, antispironolactone, while the overall endpoint the overall mortality benefit was negative. They did find a reduction in the composite endpoint. So that was the first trial that showed that. And then on the lower left of the CHARM preserved trial was actually a trial in people with diastolic heart failure, or heart failure with preserved ejection fraction. These are patients who had an ejection fraction over 45%. And you can see here that the overall endpoint was negative, but there was a trend towards a reduction in hospitalization. Again, this is an old trial. This is from almost 20 years ago, but this was one of the first trials to show that some of these therapies might be beneficial in patients with the preserved ejection fraction heart failure. Okay. I want to talk about the aldosterone antagonists. This is with spironolactone. This is from the Rawls trial. This is published over 25 years ago now by Dr. Bertram Pitt at the University of Michigan. And this trial was also kind of a game changer. This trial found an early reduction in mortality with the addition of spironolactone, which is an aldosterone antagonist, and when it's added on to standard therapy. One of the limitations of the Rawls trial was that this trial was published in the late 1990s when many patients in the trial were not yet on a beta blocker. So now that we use beta blockers routinely, some have questioned the benefit of aldosterone antagonists in congestive heart failure. However, even some of the newer trials have shown that aldosterone antagonists are very beneficial in systolic heart failure, even in people on beta blockers. This is data from the TopCAT study, TOPCAT. This is a trial that I was involved in about 15 years ago. And this is looking at patients with heart failure with preserved ejection fraction, with an ejection fraction over 45%. And this trial found that at least in patients in the Western Hemisphere, in the US, Canada, and South America, it found that compared to placebo, there was a reduction in hospitalizations with spironolactone compared to placebo. Interestingly, in some of the Eastern European republics, such as Russia and the Republic of Georgia, they found that there was really no benefit. One of the findings that's come out with post hoc analysis was that the diagnosis of heart failure was not necessarily confirmed in these patients in the Eastern European countries. Many of the patients had normal BNP levels, so they questioned whether the patients who were enrolled really had congestive heart failure or not. This has actually made its way into the guidelines. The current American College of Cardiology, American Heart Association guidelines do give spironolactone a Class 2B recommendation for diastolic heart failure or heart failure with preserved ejection fraction. So while it's not mandatory, I do consider it to be a reasonable add-on therapy if it can improve symptoms and reduce hospitalizations. Ephesus was a trial using eplerenone, which is a more selective aldosterone antagonist. It doesn't have the gynecomastia side effect that spironolactone does. This is a trial looking at people post-myocardial infarction, and this trial found a substantial reduction in mortality in patients with heart failure following a recent MI. I want to spend a couple of slides on Entresto. Entresto is sacubitril valsartan. So as we discussed earlier, valsartan is an angiotensin receptor blocker. Sacubitril is what's called the neprilysin inhibitor. Neprilysin is an endopeptidase that breaks down the vasodilatory peptides that are increased following treatment in congestive heart failure. So it basically prolongs the vasodilatory effects of these vasodilator medications. The paradigm trial enrolled patients with congestive heart failure, ejection fraction less than 40%, who were class 2 through 4. They had to have an elevated BNP level, as shown below, or they had to have a recent hospitalization within the previous year. It had a run-in phase. All patients had to be treated with either an ACE inhibitor. In this trial, they used enalapril 10 milligrams BID, or they had to be on an existing dose of an ACE inhibitor or an angiotensin receptor blocker, and they recommended that patients be on a beta blocker as well. They encouraged that all patients be treated with an aldosterone antagonist as long as there's no contraindication. Some of the key exclusion criteria: anyone with a history of angioedema, because that is a concern with either ACE inhibitors and angiotensin receptor blockers. They excluded patients with advanced chronic renal failure with the GFR less than 30, or if there was a drop in it. They excluded patients with modest hyperkalemia. If there was a requirement for treatment with either an ACE inhibitor or an ARB, for instance, if somebody had uncontrolled hypertension, that might be an indication. Anyone who develops symptomatic hypotension either at the time of screening or after the run-in phase. They excluded patients with acutely decompensated heart failure, so this is a drug for people with stable heart failure. Any history of severe pulmonary disease or any recent major event within the preceding 3 months, they were excluded. And this is also a game-changing trial. What they found, if you look at the slide on the right, they found that compared to enalapril, the study medicine Entresto had an over 20% risk reduction in the risk of hospitalization. And on the left side, they found also about a 20% reduction in death. So this is a pretty substantial finding here. And as a result, the ACC/AHA guidelines were updated to now recommend Entresto as first-line therapy for patients with new-onset congestive heart failure, especially with a reduced ejection fraction. This is a slide from the what's called the Pioneer study. This is a trial looking at patients with acute heart failure who were started on enalapril versus sacubitril valsartan as an inpatient. And what they found was that as early as 1 week after randomization, they did see a substantial reduction in the NT-BNP level, and this translated to a reduction in readmissions for heart failure as early as 8 weeks. So as a result, in my own practice, I started using sacubitril valsartan almost exclusively in these patients. I've pretty much moved away from using ACE inhibitors or ARBs in patients with congestive heart failure. The only time that I might still use an ACE inhibitor might be in somebody with symptomatic hypotension if they can't tolerate sacubitril valsartan. And in the randomized trial, sacubitril valsartan did have double the amount of hypotension compared to the ACE inhibitor arm. So if somebody is limited by hypotension, that will be one group of patients that you would not want to use the new medicine. I didn't include a slide on it, but sacubitril valsartan has been approved for diastolic heart failure as well. It has been shown to reduce hospitalizations in people with diastolic heart failure as well. I want to spend one slide talking about ivabradine, which is a potassium channel blocker in the phase 3 action potential. This is from the SHIFT trial. They enrolled patients with congestive heart failure with a reduced ejection fraction. They had to have a heart rate greater than 70 at rest, and they had to be in sinus rhythm. And they randomized into placebo versus ivabradine, which is a potassium inhibitor. And they found that compared to placebo, the study medicine lowered the risk of hospitalization for congestive heart failure. There is no mortality benefit. One concern about ivabradine is that it does increase the risk of atrial fibrillation. So the presence of atrial fibrillation is a contraindication of using this therapy. As a result, I personally have not used this in my practice only because although it reduces hospitalizations, if it increases the risk of atrial fibrillation almost equally, I consider that to be kind of an adverse event for the patient. So I personally haven't been using this very much in my practice, but you might see it used from time to time. I want to talk about device therapy for congestive heart failure. This is a slide from what's called the SCUD-HEFT study, the SCD-HEFT study. This is a study that looked at patients with congestive heart failure, ejection fraction less than 35%, and there were 3 arms to the trial. They got randomized to placebo, to amiodarone, or to an ICD. And they found that after about 12 to 18 months, those patients that received an ICD had a reduction in mortality compared to the placebo arm. Interestingly, patients who were randomized to amiodarone really had no mortality benefit either. So historically, it was felt that amiodarone reduced the risk of sudden death from ventricular tachycardia, and this trial basically showed that it was no better than placebo. So if you have somebody with systolic heart failure who's on optimal medical therapy, really consider referring them for an ICD to give them further reduction in sudden cardiac death. This is a trial looking at the role of CRT, cardiac resynchronization therapy. Patients with congestive heart failure, if they have a dilated cardiomyopathy, they can have a left bundle branch block, which can worsen heart failure. So the addition of a third lead, a left ventricular lead to a pacemaker, a so-called cardiac resynchronization therapy device, can substantially improve symptoms and reduce not only hospitalizations for heart failure, but also mortality as well. I think that's my last slide. I want to thank you for your attention, and I'll be happy to take any questions if there are questions from people who are watching.
Ayman, your mic is muted.
Okay. So I was saying that we have received some questions that we'll forward it to you in the end.
Okay.
So are there any other slides left? Am I audible now?
I can hear you.
We have received a question that what lifestyle should a person adopt to prevent heart failure?
That's a good question. Yeah, a lot of the risk factors for cardiovascular disease are also linked with congestive heart failure as well. From the Framingham Heart Study, which has been done here in the United States since the 1960s, hypertension is probably one of the biggest risk factors for congestive heart failure. So finding ways to improve hypertension, eating a low sodium diet, not only prevents the development of hypertension, but also helps downregulate the renin-angiotensin system. That's one approach that could be there. Atherosclerotic cardiovascular disease or coronary artery disease is also a risk factor as well. So generally eating a low-fat diet, eating a healthy, heart-healthy diet can help. Regular exercise training has been shown to have benefits as well. Cigarette smoking is also a big risk factor as well. Cigarette smoking is interesting because not only the direct effects on coronary artery disease and hypertension, but cigarette smoking also causes endothelial dysfunction. And there are some studies that suggest that endothelial dysfunction might be linked with developing congestive heart failure. So I think generally eating a heart-healthy diet and having a good lifestyle is important.
And are there any indicators in the CBC report that could indicate towards heart failure?
You mean the CBC, the complete blood count? Yeah, that's a good question. Anemia there's a lot of studies that have looked at the relationship between anemia and congestive heart failure. Patients with congestive heart failure who have iron deficiency anemia tend to have a poor prognosis for a variety of reasons. It might be a marker of poor nutritional status. It could be a marker of poor iron absorption, which can have adverse events as well. It can be a sign of chronic inflammation as well. Anemia can be caused by inflammation. So I think those are really the things to look for. If you look at the MCV, if somebody has microcytosis but they have a normal hemoglobin, that may be a patient where you might want to institute iron therapy to prevent the development of anemia. So I think those are some things that I would look at on those results.
Okay, and we have another question that is liver cirrhosis in any way linked to heart failure, or it can lead to heart failure?
That's a good question. So cirrhosis can be caused by congestive heart failure, so-called cardiac cirrhosis, especially people who have advanced heart failure with right ventricular involvement. I saw a case of that recently, actually, a patient who had cirrhosis, and it was due to the heart failure. I'm not aware of a link between cirrhosis and congestive heart failure. There's increasing research going on with the role of NASH, of non-alcoholic steatohepatitis, and ischemic heart disease. That's kind of a recently looked at entity. Now, the challenges with that disease is that people who have NASH tend to have other cardiovascular risk factors as well. Many of them are diabetic, they have obesity, they may have hyperlipidemia, either primarily or as a result of their NASH. So it might be confounding it, but there is a link between, I know, non-alcoholic steatohepatitis and coronary disease, but I'm not aware of any direct link between cirrhosis and congestive heart failure at this time.
And what are the chances of a patient who is having an advanced renal disease? Can that person be predisposed to heart failure?
Yeah, so congestive heart failure, that's an excellent question. Congestive heart failure does complicate renal failure in a lot of situations. These patients are prone to fluid retention, so that's one link there. But also many of these patients have the same comorbidities. They have hypertension, they have atherosclerosis, they have other comorbidities that can link it. Treating heart failure in patients with renal failure is very challenging because, as we showed, many of the therapies that reduce mortality also work through the kidneys. ACE inhibitors, ARBs, and aldosterone antagonists. Aldosterone antagonists really can't be used safely in people with advanced renal failure. I've seen some people use them, but I tend to avoid using aldosterone antagonists in people with creatinines over 2, just because of the risk of hyperkalemia. You can use ACE inhibitors, ARBs, and even Entresto in people with advanced renal failure, but you just have to be very careful about the creatinine and about the potassium. So it can be very challenging to treat these patients with. Another big point of controversy is the use of device therapy in patients with renal failure. Although ICDs have a substantial mortality benefit in most patients with congestive heart failure, they really haven't been shown to be beneficial in people with renal failure. If I have somebody with renal failure, I'll still refer them to our electrophysiologist and consider them for it. But the data showing that their benefit is controversial in those patients. So that is a very challenging group to treat with heart failure.
So what is the prognosis of heart failure? I mean, if someone has it, so what are the survival rate for it, and how much it's gonna affect the life of that person?
That's a good question. Historically, heart failure had a very guarded prognosis. Some of the earlier slides from only about 10 or 15 years ago showed that mortality was as high as 50% at 5 years. It was actually worse in some cancers. We've made great progress at treating cancers, but congestive heart failure was still a very serious condition. I think over the last 20 years, 25 years, we've seen substantial improvements in the pharmacotherapy. I think the very first one was the vasodilator hypothesis, when it was shown that heart failure is a state of neurohormonal activation, elevated catecholamines, upregulation of the renin-angiotensin system. That's a direct link to mortality. So the drugs that block that axis, the ACE inhibitors, followed by the ARBs, and then the beta blockers, and then the aldosterone antagonists, all those drugs work along that axis. And then most recently we have Entresto, which has been shown to be better. I did not talk about SGLT2 inhibitors. I didn't want to overwhelm everyone, but SGLT2 inhibitors are the latest development in congestive heart failure. Both empagliflozin, which is Jardiance, and dapagliflozin, which is Farxiga, have been shown to substantially reduce hospitalizations and also mortality in patients with congestive heart failure. Currently, we recommend a 4-drug cocktail. We recommend beta blockers, Entresto, an aldosterone antagonist, and then an SGLT2 inhibitor. It's been said that if patients are on all 4 of these medications, you can reduce mortality by as much as 80 to 90%. It's still a very serious condition, and we don't know how these patients will do long term. But that 4-drug combination has been shown to be very, very effective at reducing hospitalizations and mortalities. So I think the key is, I think prevention is always important. I think that if you can prevent the hypertension and the diabetes and the coronary disease, that would be the first thing to do. But once somebody develops symptomatic heart failure, I think early implementation of these standard medications. When I see somebody in the hospital now with congestive heart failure, unless there's a major contraindication, I'll discharge them with 4 medications, with carvedilol, spironolactone, an SGLT2 inhibitor, and then Entresto. And then I see them in follow-up, and I titrate pretty frequently. If somebody develops hypotension or renal failure, I'll probably stop the spironolactone first. I think that probably has the weakest data, but I think most of these drugs are very well tolerated. Early referral for cardiac rehabilitation has also been shown to reduce hospitalization and even mortality in patients with systolic heart failure. So I think I think it's still a serious condition, but I think the prognosis has gotten much better with all the drug therapies we have now.
Okay, so thank you for addressing all these questions, and we are really glad that you came today for our webinar. It was really a very informative session, and everyone who was in this webinar really enjoyed it, and it was really informative.
Thank you, Ayman. Do you have any other questions?
No, I don't have any other questions, and it was really very informative.
Okay.
He addressed everything so well that I didn't have many questions.
Anybody have any other question?
If any of you have any questions,
write in the chat.
You can ask in the chat box.
So thank you everyone for coming in the webinar. So this webinar is co-sponsored by Ayman and me. I am a CEO and founder at Biospiel. let me explain to you what is Biospiel. So let me share my screen. Thank you, Dr. Shyam, for your precious time. Really appreciate it.
Thank you.
Are you able to see my screen?
Thank you. Yes.
Yes, I can see your screen.
This is biospiel.com. It's a medical collaboration platform for doctors, radiologists, radiographers, radiology technologists, medical professionals, students,
No.
cardiologists, students of medical science, scientists, and researchers. So, okay. So in this platform, medical professionals can share and collaborate on medical cases. For example, CT scan, X-ray, MRI, ultrasound, and they can get second opinion. They can get expert advice. You can collaborate with peers in the medical community, and it's 100% free to use. You can post medical cases. You can ask from peers in the medical community. Let me give you a demo. You come to this biospiel.com. You click on sign up button. You can write here if you're a medical professional. Let's say you're a medical professional. Write your first name, your last name, your email, you write your password, confirm password, write your institution name, select your country. Let's say you are from Albania, specialty, select your subspecialty, verify your credentials, photo ID, upload your school ID, institute ID, license, professional registration certificate, or clinical degree certificate. This is for your verification. After you upload it, click on register button, follow the steps. I already have an account, so I will just log in. So let me log in. So I have just logged into biospiel.com. This is the home feed. You can see some medical cases being published in the home feed. Medical. This is ultrasound. This is the X-ray radiograph of the forearm. This is another. This is MRI. This is radiograph of the wrist. And you can post all the cases. So you can see this plus button. I click on plus button. I can share a case, share a decision, post an article, create an event, create a group. Let's click on share a decision. Doctor make decisions every day in clinical practice. The decisions they make in clinical practice, they can share it here and they can get a reward. Will get a virtual currency coin. Let me show you how. Upload a decision picture, images, video. Let's say a patient is suffering from COVID-19. Let's say I upload a chest radiograph. Chest radiograph of a patient suffering from COVID-19. Enter patient diagnosis, symptoms, clinical findings, enter judgment treating a patient. You can write here all the judgment you made in treating a patient, your decisions, your treatment plan, how you planned the treatment of the patient and everything. For example, doctor can say, I treated the patient suffering from COVID-19 and so on. And talk about everything, the decision he made, talk about the, especially let's say radiology, subspecialty, let's say other clinical. I agree and click on share our decision. After you click on share a decision, you share the decision. We will review it for our privacy policy, and because of if it's according to our standard, we will publish it and share it with the community. Your decision has been sent to a moderation team for review. Ensure patient privacy. Every decision is reviewed before being shared on Biospiel. You will be notified once your decision is available to the community. We will review it. This decision is in review. If I go to my profile, let's see, on profile picture, my profile. This is the profile of the user. As you can see, here are 25 decisions already published. See all. This decision I just published, it's pending. 24 are published. 24 decisions are already published. I go back. It says 24 coins. If you want to earn one coin, you must make one decision. Coins are like reward points. For example, one coin is equal to one decision. This is the cryptocurrency coin being using Solana blockchain. This transaction will be recorded in Solana blockchain. For example, doctor made a decision. You can share a decision. After it is published, he will receive a coin. But right now there are 24 coins. That means there are 24 decisions already published. One is pending. After it is published, then you will get one coin. It will be 25 coins. So it's a reward. We are introducing gamification in medical collaboration where doctors share decisions they make in clinical practice, and they will get a virtual currency coin in the form of cryptocurrency. And we are using Solana blockchain. Solana blockchain we are using. So if I can click on plus button, I can also create a group. For example, if I want to create a group, I can upload a picture of the group. Let's say cardiology group. About the group. This is a cardiology group. Group type public group, and let's create a group. So I created a group, cardiology group, and it's a public group. So it's a public group, and it's loading. Let me show you some of the groups already being created. These are the medical student. This is the medical student group. As you can see, there are 9 members in the group. This is a medical student group, and he can people can talk about anything in the group related to students' studies. So as you can see, there are also post an article and create an event, just like LinkedIn event, Facebook event, and everything. So let's say these are the posts being published in the group. As you can see, some posts in the group. It is also a chat function. User can also send a message to all the users. So just like Facebook chat or LinkedIn chat, you can also send a message to the user in the form of chat. And there is a create an event. Here you can create an event. Let me show you some events already being created. So AKU seminar for radiology medical student gathering. This is the event created on 23 November, where students gathered for a radiology seminar. You can create events just like Facebook events, LinkedIn events. You can create medical events here. As you can see, this is the event created by the user. AKU seminar for radiology. This is the offline event, and you can talk about. You can invite your peers in the event. Invite peers in the event. You can invite people in the event here. It's a social computing platform for doctors, radiologists, students of medical science, scientists, and researchers, and it's 100% free to use. Please join it. Do you have any other? Anybody have any question? Anybody has any questions regarding this platform? So I think nobody has any questions, so I will just log out. So I will just, I have just logged on.